All right. Well, welcome everybody to this week's Journal Club. So I hope you're all feeling energetic and enthusiastic. I can feel that energy. So today's Journal Club is inspired by a real scenario that I've encountered in recent practice. And I've sort of summarised it as this. A 5-year-old child attends your emergency department with a short history of acute wheeze. He's got a respiratory rate of 42 per minute with moderate respiratory distress, and his oxygen saturation's on 89% in air. You've asked the nurses to administer nebulized salbutamol, adiprotropium bromide. You're working with a junior colleague actually, so a new paediatrician, but your colleague's come through medical school much earlier, so it's much more up to date than you, and says, why aren't you adding magnesium sulfate to the nebulizer? And you have a moment of cognitive dissonance because in your mind magnesium sulfate is just a medicine that you give intravenously as escalation therapy for acute severe asthma. But it's what's that about? And so you question its efficacy. Now, clearly in the moment, you can't answer that question, and so you may have to decide what to do with that information and whether there's some reputable guideline-based information that this a new paediatrician can show you to convince you to do that then and there. But actually you come away from it with the question, okay, so nebulized magnesium sulfate for acute severe asthma, is it a thing? Is there evidence for it? So let's just see if we can frame this problem into a focused question in just a few minutes around the PICO framework. So I've given you a very specific child, 5-year-old child presenting with short history of wheeze and some evidence of severe exacerbation. So what population group should we describe as the population we're interested in?
Young children.
Young children? How young?
Under 5.
Under 5.
Under 5. Well, he's 5.
He's 5 years old. 5 years old.
1 to 5.
Okay, inclusive. Okay.
Yeah.
Yeah. So we could say we're interested in sort of
2 to 16.
But I mean, you remember, we can frame the question how we want, and of course we may frame the question, the evidence may not perfectly stack up with that. We're talking about a 5-year-old, he's a sort of young, school-age child, so, you know, and you'll recognise that there tend to be particular types of age ranges that studies pick, but 1 to 5 wouldn't quite cut it. You know, I mean, 5 to 8 would kind of, yeah. Anyway, so we could say children aged 5 to 9 years old presenting with what? What sort of problem?
Severe acute asthma.
Acute severe asthma. Okay. Yeah. And anything else we need to specify, or is that okay?
That's 5 to 8, 9 years old.
Yeah.
With severe acute asthma.
Yes, I think that sounds good. And what's the intervention we're interested in? Nebulized magnesium sulfate. Okay, excellent. And what are we comparing the nebulized magnesium sulfate to? Standard of care. So we can just say SOC, standard of care. And what outcomes? So when someone says, "Oh, magnesium sulfate is effective," what's going to define its efficacy? What is it we're interested in?
So PICU admission,
Okay.
intubation.
Okay, so PICU admission, intubation, yeah. Length of stay, mortality, yeah.
Resolution of symptoms.
So okay, so symptom severity, something like that. So symptom severity. Okay. And so what sort of time course, we often say PICO-T, what sort of time course are we going to assess these over? What sort of time course will we be thinking about PICU admission?
So the admission will happen there and then, like in the next few hours if it's going to happen.
Yeah, because you've got to have some sort of idea. So within hours, you could say maybe 4 hours, that's probably not a bad idea. And in the UK, 4 hours makes sense in an emergency department, because that's just sort of how long you've got to make a decision in. Intubation,
Yeah, that needs to happen fast.
So that could be similar. Length of stay obviously is just length of stay, so you can't really apply a time scale to that. Mortality, what sort of time window would we be thinking about?
If they're going to die from asthma, they're going to die in
24
hours.
24 hours, okay, that sounds really sensible. And when would you be interested? So thinking about, how magnesium sulfate might work, at what point do you think it might be good to assess symptom severity?
1 to 2 hours.
Yeah, we're thinking about a very acute effect. So we're thinking about sort of 1 to 2 hours. Okay, any other sort of, there's something generic we often throw into any intervention outcome that we always ask about. When we give someone a new drug, we're interested to know if...
Side effects.
Yeah, so adverse effects. And again, you'd probably be thinking about a drug like this over a day. Okay, so there you go, a little bit of work. We've got a nice framework. So, you framed a really nice question there. We've got a bit of evidence here, but before we have this evidence, you've all told me before that you've not come across this study. But you may have had teaching, you may be aware of guidelines, of what guidelines suggest. So how many of you already, for a child like this, would have said, yes, I would like to give nebulized magnesium sulfate when I see this patient? Anyone? Okay, good. So I'm going to mark that as so we started with 0, 7, 8. So 0 out of 8 interest in giving nebulized magnesium sulfate. Okay, great. So this is the point where we're now going to look at the evidence and we're going to see if that affects our views.
Yeah.
So I'm going to divide you into 2 groups of 4. So the division point is here.
Okay.
So try and get yourself so that you can sort of have a little bit of cooperative chat. You should all have a copy of the paper. Is that right?
Yeah.
And then if you have just sort of what you're each going to have one little worksheet just to help you formulate your appraisal. But you can, there are extra ones if you need them. And I would like this group here, these 4, if you could consider the validity of the study. Now you'll remember, I hope, that means you don't need to...
We don't do the silly math.
Yeah.
So that means you don't need to read the introduction, you don't need to read the conclusion, you really need to focus on read the abstract, get an overview of the study, read the method, and always the method and then table 1, which is usually your demographic table. That's also important for the validity. So that's your job. You've got a framework to go through. I mean, you might want to spend a little while reading and then start to sort of chat about it amongst yourselves. Any problems, just sort of shout to me I'm around or solve them yourselves. Over here, this wonderful group of 4, you're going to consider primarily the results of this study. So that means I'd like you to read the abstract and then dive straight into the results section of the paper. You might find that sometimes you need to glance at bits of the paper to understand what they've done, but by and large, the results should speak for themselves. Yes, so you're going to be thinking about those results. And again, if there's anything that doesn't make sense, anything that's confusing, escalate that to me and talk it through. And then once you've all done that, so I would intend on probably somewhere between 20 and 30 minutes for that. We'll see how you go. We'll then get the groups to feedback, and we'll then think about the next bit, which is the applicability of that to our patient. Okay? So fire away, and I'll just...
Okay, so our pico is that one.
Yeah.
That one,
Okay, so what's the patient what is best? Central computerized.
All right. So are we good time to feedback?
Yeah.
All right, great. So unsurprisingly, we're going to start over here with gosh, how did you end up with likelihood ratio?
No, we
Oh,
were
no,
just
no, no.
Oh, yeah.
We're smug because we didn't get the maths part.
Yeah.
So we're like, we're going to ask them about that.
So, unsurprisingly, we're going to start here with you guys thinking about the overall validity of the paper, how they did the study, and whether that means we should even bother looking at the results. In which case, we can all just go home early. So, who's going to feed back to us?
Okay.
Yeah.
You've been volunteered.
Yeah. So on the validity of the study, so the first part was the assignment of the patients to treatment randomized. Yeah. And it was very good. We're very impressed with it. It was firstly stratified by center,
Yeah.
and then there was block randomization done for the patients, and then they were doing it blocks of 2 to 4, and also with a ratio of 1 to 1. So it's very hard to predict what the next patient is going to get.
Okay.
Yeah.
So for the purpose of your colleagues who didn't appraise the study, and because sometimes when we go a while without thinking about these things, we forget what they do.
Yeah.
Can you remind your colleagues what the block randomization achieves and what the stratification achieves?
Okay.
No pressure.
So stratification, because this study was done on 30 centers across the UK. So if you stratify by center, you're trying to make sure that you get fairly equal distribution of treatment and control across the centers in the UK. Because by chance, you may end up with more of the patients receiving treatment in some of the centers than the others. So that's what it does. Then when you get to the block randomization, this is now in the center at the level of the patients. And they were doing it in blocks of 2 to 4. So you can say you pick 4 blocks. So for the next 4 patients, you've got a computer-generated random order in which you're going to give. So you're going to say, maybe in that sequence of 4, maybe you're going to do 2 treatment, 2 placebo.
TTPP.
Yeah, TTPP. Or it could be TA, or TP, something like that. So then it ensures that for the patients you have, like they will receive, there's a fairly equal chance that a fair chance of them receiving either treatment or placebo. Yeah.
And then because the next one is 2,
Yeah.
say if you were suspicious as a clinician, you're like, I think it's a and I can predict. Then because it's 2 and then it changes again to 4, it mixes it up a bit.
So they all work together, just to emphasise. So the block randomisation means that you can never get a significant imbalance between the control and the intervention. You can't finish the study and end up having 210 getting the treatment and 290 getting the intervention, which you wouldn't want.
Yeah.
So it means you're still randomising each patient's still 50-50, but you avoid the possible extremes that if you were just flipping a coin, because you're only picking blocks that have 2 of control and 2 intervention. You then vary the block size between 2 and 4 in this case to make it harder for clinicians to predict what the next patient might get if they've worked out what the preceding patients got. And then finally you then stratify those sequences by centre so that the randomisation sequence for hospital A is separate from the randomisation sequence for hospital B, so you ensure the same within the hospital. So actually within each hospital you're going to have a fair balance between intervention and control. And that all means that you can have more faith in the ultimate outcomes because it's the drug and control difference that are making the difference rather than that, oh, you accidentally ended up with more people getting control at one hospital than the other, and that was the difference. Great, okay, so we're happy with randomisation.
Okay, were the groups similar at the start of the trial? Yes, the groups were similar, and there was a table in page 3.
Big table, basically.
Yes. So, and it shows that most of them were similar in age, and most of the characteristics there were similar for both groups. It was almost balanced. And then they all had the severity of symptoms were the same, and they used a single score for all of them to classify the severity of the symptoms for each patient.
Yeah. So the groups were actually remarkably similar, so that's good.
See,
That's what
we've got A, B.
Yeah.
So aside from allocated treatment where the groups treated equally, I think so. So it says in the method that the assessment was made on all patients, and then because the treatment appeared the same, like clear colourless liquid, goes into a nebule pot, then they to the patient it would have appeared that they all received standard treatment, and to the clinician as well. I don't think they could have done it any differently, but just to and they spelt out that they received standard treatment within the first hour according to the hospital, and then they would get the three mixed nebs with the extra saline oil. Yeah. So we think it was
They were treated equally.
no special treatment.
So So 2B said, were all patients who entered the trial accounted for? And were they analysed in the groups to which they were randomised?
Oh, I don't think we know.
Yeah. Well, yes, they were.
Yeah, they were accounted for.
Yes, figure
So
one.
look at the flow chart.
Figure one?
Yeah.
Yeah.
So they gave all the patients what happened to them, those that dropped out, why they dropped out.
Yeah.
And then analyzed in the group to which they were randomized because they said there was intention to treat principle with two-sided p-value for both of the groups.
Yeah.
Question 3 was, were measures objective or were the patients and clinicians kept blind to the treatments being received? Yes, it was objective. It wasn't according to what they wanted. They followed the YAS to assess the severity, and everybody was blinded to the treatment. So
Yeah. And what over here? Anything to add on that? So blinding, yes. Objective measures. Were the measures objective?
Yeah.
All of them.
I suppose if you have a hearing
Except the side
impairment.
effects. Probably the adverse effects.
Okay.
Adverse
And what about the asthma severity score itself?
It was objective.
It was objective because they said that the severity score has been shown to have good inter-observer reliability with an overall
And then
proper score.
So overall, people tend to agree on the asthma severity score. Yes.
It's with the patient. Well, there is with but
Do they have wheeze or not? Is it expiratory, inspiratory? Expiratory can hear it at the end of the bed, so that's fairly objective. But it does require, it is a judgment at the end of the day on the part of the clinician at the end of the bed. It's not a number you're reading off a machine. Accessory muscle use?
Yeah, I suppose.
Yeah.
I suppose you can't. Yeah, I suppose what looks mild to you might look severe to me. That
could be.
It's a little subjective.
But
But at the end of the day,
different clinicians.
the good thing is, although there are elements of subjectivity in that score, what they're able to point to is that it's been validated. So it's been shown that that score correlates with other objective measures of asthma severity, like the FEV1 in some populations, and that clinicians tend to agree quite well about the score. So actually, blinding is well achieved. It's not perfectly objective, but you'll notice the question, it says, were they blinded or were the outcomes objective? Because in a sense, it's when both of those are negative that you've got the problem. If there's no blinding and the outcomes are subjective, you've got a real problem. Because the clinician knows what they got and then has to make a judgment. So intrinsic bias may have an effect. If they're not blinded but the outcome is objective, then that shouldn't matter as much unless there's fraud. And if the outcome measures are if there's blinding, then a subjective outcome measure is not so critical, because in a sense, even if there's bias, it's not being applied on the basis of which treatment people receive. Other biases will come into play, but hopefully not the treatment one. Yeah.
I have a little issue about the two medications, like who labeled or how was that managed? I didn't pick that up.
Okay, did they say in the message about
because
that?
someone has to know.
Yes, there's somebody who has to know what was given to
Okay,
The manufacturer. They said something about the manufacturer.
Yeah, they said something.
The manufacturers.
But they said the randomization sequence was generated by an independent statistician at the Medicine for Children Research Network Clinical Trials Unit, who had no further involvement in the study.
So they were not.
But that was for the patients. I'm talking about
the actual medication.
Yes, the actual medication.
But actually, what's interesting is this is a common way of doing it. The medications were actually in a sense, the randomization instrument. So they generated a sequence for hospital A, and let's say the sequence looked like, let's say this was the sequence, literally in order, CC, IC, IC, ICC. What they did then was the company that made the drugs, they made pack 1, and that had the control in it. They made pack 2, and that had the control in it. Pack 3 had the intervention. Pack 4 had the intervention. Pack 5 had the control. So actually all they've got is in the pharmacy, they've got a box with sequentially numbered bags for the drug. So the first patient recruited at hospital A gets the first bag. The second patient recruited gets the second bag. So actually, in a sense, so the randomization sequence is the order of the drugs in that.
And they actually said the placebo and active treatments were manufactured by St. Mary's Pharmaceutical
Yeah.
Unit.
So they would
So
know.
both treatments were clear, colorless, you know.
Yeah.
And so that means, you know.
They would
So the
know.
pharmaceutical unit would know.
No.
Yeah.
Yeah.
Okay.
Be
Good.
difficult if you have to
Someone
prepare
So-
it, because it's all pre-made.
Yeah.
So the question we have to ask ourselves at this point is, do we all pack up and go home, or is it worth thinking about the results of the study?
What thinking
Oh,
about the results.
good, excellent, excellent. So you've not wasted your time. So what do you want to tell us about the results of the study?
So they looked at a few different outcomes. The primary outcome that they looked at was the asthma severity score.
Yeah. So we'll call it the Young Asthma Severity Score to avoid the obvious acronym. Yeah.
And they were looking at that at 1 hour
Yeah.
sort of post-treatment.
60 minutes. Yeah.
And they did that by looking at the difference in the mean asthma severity score between the two groups. So there was an initial difference in means of minus 0.24, which then became minus 0.25 when they adjusted it for baseline asthma severity score. So to sort of put that into more context, it means that there was a drop of 0.25 of the severity score for patients in the treatment group versus the control group. So for sort of 1 in 4 of the children treated would have had, well, one in 4 of the children treated would have had a decrease of 1 severity score point compared to the controls. It's a statistically significant difference that they report, but it's a little bit tricky because the authors stated that they were looking for a decrease of 0.5 at the start of the study, and they've not achieved that to be a clinical sort of significant difference.
Yeah.
So,
Okay. And what? So you said it's significant. So let's show the confidence intervals then of that estimate.
so it's minus 0.48 to minus 0.02.
To minus 0.02. Okay. Fine. And what was the p-value that they gave?
0.006.
Okay. Is that right?
No, 0.034.
0.34. Okay. And does anyone want to hazard a sort of plain English description of what that p-value means? It's always helpful to cement that in our heads. When we say that the p-value for that difference is 0.034.
Is that 34 out of
How many
1,000
Mm-hmm.
chance of these outcomes happen just by chance?
Okay, nearly there. Nearly there. So most of the important concepts are there, but there's a bit missing from that will cause misinterpretation. So can anyone add a little bit to that statement?
I think we're 95% confident that 34 out of 1,000 children, in that the results that we had occurred in 34 out of the children of 1,000 children just by chance.
Okay. Not quite. And actually, when we're talking about confidence, is kind of putting it into the world of confidence intervals. And although there's a symmetry between p-values and confidence intervals, they're kind of some slightly different statistical ways of looking at it. So the interpretation is slightly different. So the confidence interval is telling us that we're sort of 95% confident that the mean difference between asthma severity score at 60 minutes lies somewhere between minus 0.02 and minus 0.48. So that's kind of one way of looking at it. That said that we started off by not having a clue what the mean difference was. With this evidence, we now have 95% confidence that the value lies somewhere between these two. The p-value is something slightly different. And you nearly had all of the right things in there. You talked about this is the chance, so you said 34 in 1,000, or we could just round it and say 3 in 100. Chance that it was sort of a fluke result. The problem with that is that leads us to the idea that there's a 97% chance that it's a real result. But actually that's not the way it works. The p-values, remember, this is about a hypothesis test. So a hypothesis test only makes sense. You have to express something about the hypothesis for the p-value to make sense. So what's the hypothesis that the authors of this study were really interested in proving? What did they want to show?
They wanted to show that magnesium
They
sulfate.
wanted to show that there's a difference.
Yeah.
So what do? They set up a null hypothesis that they want to try and knock down. And what was their null hypothesis that they built? That magnesium sulfate does nothing.
Yeah.
So the p-value is calculated as if we lived in the null hypothesis world. So the p-value says if we lived in a world where magnesium sulfate had no effect, then how likely would it be for us to get a result like this, or more extreme, so minus 0.25 or less, or in the other direction, plus 0.25 or more? So in other words, how likely is it for us to get a result in this tail of the distribution if we lived in a world where there was no real difference? And in this case, it's saying it's about 3 to 4%, so 3 to 4 in 100. So the one way I like to express it is it's the index of surprise. So if you picked up this study and you already knew that magnesium sulfate did nothing, you had good reason to know that it was ineffective. It's how surprised would you be by this result? So this says we should only get this result 3% of the time, 4% of the time, if magnesium sulfate did nothing, which is reasonably unlikely. But it's not impossible, is it? 3% things happen all the time. Yeah? So, so what else might help us interpret that p-value? Can we bring anything else to the table to help us think about whether we should believe in our heads that we can reject the null hypothesis? So they kind of give it in the introduction, actually, which I told you not to read, but it's the kind of biological plausibility. Yeah? So if you get borderline statistical significant evidence for something that's biologically implausible, then I think you're kind of reasonable to say, actually, I think we really need some more evidence. In this sense, we're actually talking about a drug that we have good evidence is effective intravenously. And they talk in the paper about animal model evidence of efficacy, and they talk about evidence of efficacy in animals. So in a sense, with that background, you can sort of say you're walking into this study with a prior sort of reasonable expectation that magnesium sulfate may be effective. So actually, the level of evidence that you require might not be quite so high. And actually, so there is that sense. We like to think of our statistics and our science as totally objective. But it can't be, p-values can't be, because no matter how extreme the result is, it could always have arisen by chance. So making that judgment as to whether the result is sort of striking enough to reject the null, I think should take on board something of that kind of prior evidence. And ultimately that's why people like to pool all the results together and do meta-analyses when you have lots and lots of different trials looking at the same question. So for my part, although this isn't the most striking statistically significant result, the study was really done in a very good way, and I felt that it was biologically plausible and already evidence to have effectiveness in other domains. So I was quite happy in my head to think, well, probably this is a real result. But yeah, so we come to this point about, so what did you think? Were you impressed by the efficacy of magnesium sulfate?
I think that brings us to the secondary
outcomes. Okay.
Because when we tried to calculate the relative risk for step down of treatment at 1 hour, we had a relative risk of 0.9.
Yeah.
And
did you have a confidence interval around that, out of interest?
No.
Okay, don't worry.
Yeah, so we didn't do that.
That's all right.
And then we had an absolute relative risk.
Absolute risk reduction, yeah.
Sorry, absolute risk reduction of 0.03, and then a number needed to treat of 33.
Okay, so 33 needed to treat to prevent, to have one additional patient stepping down. Okay.
So
the only thing we need to remember there is that because this is a non-significant result, that confidence interval would actually be wide, and it would be 33 up to infinity, and it would also include the possibility that the treatment reduce the chance of stepping down. Yeah. But can you see from the results what the confidence interval was around the
step down?
Yeah.
It was
so
0.05.
Okay, so that's the absolute risk reduction. So they're saying it could be anywhere from a 5% increase. Sorry, 5% reduction in step downs to an 11% increase in step downs. So does it leave open the possibility that it has a significant effect, a good effect on step downs? Yeah. So actually it's totally consistent that there could be an effect, but we haven't proven anything. Okay, great. Any other of the secondary outcomes relevant?
Okay, we also looked at the number of additional salbutamol doses between those receiving magnesium sulfate and those receiving the placebo.
Yeah.
And there was a difference in one dose. So those receiving magnesium sulfate need one less dose of salbutamol compared to...
In this study, on average. And again, with a confidence interval, that became all...
-2 to 0. So they either needed 2 less doses or no additional dose, which kind of looks good.
And then they did do some slightly, what shall we say, fancy stats towards the end. When people do fancy stats, what happens? What do you think? Usually you get a headache. And one of the important things when people do fancy additional statistical analyses to know is did they plan to do it, or did they just muck around with the data afterwards? Why does that matter? Why do we care?
Because you can find a randomly significant result because of the number of tests you're doing.
Yeah. So these people who did this paper could have just sat down at the end of it and said, you know what we'll do? We're just going to run as many different analyses as we can to see if anything pings up. And then we'll stick that in the paper because it'll be interesting. And we'll be able to make the result that was not clinically significant look clinically significant. Whereas if it's pre-specified and you've got the protocol, you kind of know how many tests they've done. So you can assess whether they've done a fishing expedition or whether they've been quite focused. And the nice thing in this case is that they're pre-specified hypotheses, although the study wasn't specifically powered for it, they powered for the primary outcome. They did put it in and they said why they were doing it. They claimed pre-existing biological reasons to believe that magnesium sulfate may be more effective if the asthma was more severe or if it was of more acute onset. And they did that using a technique called linear regression, which you may have varying degrees of familiarity with. But overall, what was the sense of what they presented? What did they conclude from that analysis?
Well, we're not done presenting the results.
Oh, sorry, I'm rushing you ahead.
Okay, so let me just go ahead.
Yeah.
They also looked at the proportion requiring intravenous bronchodilator treatment. So in the magnesium sulfate group, we had 10% of the patients, and in the placebo group, we had 12%. So that gave us a relative risk of 0.83, an absolute risk reduction of 0.02, and the number needed to treat of 50. So we need to treat 50 patients for one of them to not require an additional bronchodilator treatment.
And again, importantly, was that significant?
No, it wasn't significant.
Yes.
And the last one, the proportion of patients requiring intubation or admission to PICU. So this one, the patients in treatment group have higher proportion. So it will be number needed to harm instead of number needed to treat, and the number of the difference 0.03, and the number needed to harm will be 33.3, means that when you treat 33 children, one of them will be intubated or admitted to the PICU.
Okay. And again, was that difference statistically significant?
No, the P is 0.283, and the confidence interval is between -0.02 to 0.07.
Yeah. So actually, all of those secondary outcomes were insignificant. In a sense, it's no surprise because they powered the study. They recruited enough patients to answer their primary outcome, which they did very well. They actually found a difference that was smaller than they were looking for, which means they had good power to detect that. But they've got some wide confidence intervals around those secondary outcomes, which is no surprise, and means that we can't really say much about that. And then, sorry, I kind of rushed you ahead, but what did you get a chance to have a look at the results that came from that linear regression? That's okay. So in summary, so there's a table at the end which is a little bit difficult to interpret. But what they did was that their initial analysis basically said there is one and only one thing that is influencing your asthma severity score at 60 minutes, and that's whether you receive magnesium sulfate or not. You might remember in the course we talked about the idea every statistical test we do is based on a model. So that model was the simplest model possible that they could envisage. The only thing that was causing a difference in the mean asthma severity score at 60 minutes was whether or not you received nebulized magnesium sulfate. They then built a slightly bigger model that said maybe the original asthma severity score has an impact. And you can kind of imagine those as a sort of formula, like as a line graph. You remember like y equals mx plus c from school, things like that. So their initial model said your sort of mean asthma severity score at 60 minutes. So the mean asthma severity score, actually sorry, put a bar over it, the mean asthma severity score at 60 minutes equals some number plus some other number times whether you got magnesium sulfate or not. And what they were trying to work out was how big B is, which is the effectiveness of the magnesium sulfate. They then made a slightly better model where they sort of said, okay, plus some other number times your baseline asthma severity score. Because it's quite plausible that if you started off more severe, you might end up more severe. So it's a slightly more sophisticated model. But still, the thing they were really interested in was how effective magnesium sulfate was. They then built a model that had what's called an interaction. And it looked for, if there was another term here, a difference called, which we could represent by D, which was whether you got magnesium sulfate or not, multiplied by whether you had really acute symptoms less than 6 hours. So that would be a 0 or 1. If you'd had really acute symptoms, you were a 1. If they were longer than 6 hours, you were a 0. And that meant that they were looking for, was there a special effect that magnesium sulfate had over and above its mean effect, only if you had really really acute symptoms. And so they did that for the acuity, how short the symptoms were. They also did that for the degree of hypoxia. And in that case, they put in the saturations as a continuous variable. And what they found in that table 3 was that the addition effect of magnesium sulfate in patients with an attack in the past 6 hours or less, which is this thing here, D, they said that that was minus 0.79 and had a confidence interval that just excluded 0. So quite nicely they sort of showed with borderline significance what they had hypothesized, that magnesium sulfate would have a greater effect when people have very acute symptoms. And what's interesting, if you've done regression before, is if you go up to the top line of that, which is the effectiveness of magnesium sulfate on its own, once they put that term into the equation, the effectiveness of magnesium sulfate on its own basically became 0. So it's kind of suggesting that probably within that population, all of the effectiveness of magnesium, that mean effect of minus 0.24 was probably almost all in the patients with acute and severe symptoms. And they actually show much more intuitively, they show a graph, I think, which is one of the final figures. They show a nice graph which has a darker line for the predicted asthma severity score at 60 minutes if you got placebo, which shows that depending on the lower your oxygen saturations were, the worse your asthma severity score would be at 60 minutes. So basically showing that the difference appears to be better and better for the lower oxygen saturations. So it's you can't take it as strongly as you would take the primary results of the paper, but it was pre-specified, it was biologically plausible, so I guess we shouldn't throw that out. So we've got a study that we think is valid. We've got some results which are statistically significant, but according to their definition, clinically insignificant, but with evidence that some subgroups may respond better. How are we going to apply this to our patients in practice? Do we think that patients in the hospital that we work in the UK maybe would obtain the same benefit from magnesium sulfate? Are they similar?
We have it already in our treatment to give IV magnesium, and sometimes we give it within the first hour anyway, if they're very
severe,
sick.
Yeah.
But for those who haven't improved in the first hour, we would then go on to give magnesium intravenously anyway. So if it's going to prevent us from putting a cannula in and giving it, but then if the effect is just 1 in 4.
Well, that 1 in 4 was my effort to kind of apply it to the group. Yeah.
I also think we have to consider the cost of the drug and the adverse events. Granted, they said there's no difference in the adverse events between the treated group and the placebo group, but we have to also consider the cost. Because if we're going to, for example, I have an MNT of 50. If we have to treat 50 people, even though it's not a primary outcome, but if we have to treat 50 people to prevent one outcome, then it has to actually be something that is very affordable.
Yeah. So let's think about the cost. So for some treatments, you've got the cost of your drug, cost of administering it, cost of nursing time, all the rest of things that are factoring in. So what's going to be the cost in this case?
The patent.
Well, it's magnesium sulfate. Don't think that's patented. Don't think you can patent a salt like that. So I don't know the cost, but I would find it hard to believe that a solution of magnesium sulfate is expensive compared to other drugs that we would use in asthma. It should be, I would hope, treated cheaper than salbutamol and ipratropium. So let's imagine that the cost is small. Let's imagine it's on the order of sort of 50 pence or less. But are there any other burdens? Because it's also thinking about the application in practice. Does it require any more nursing time? Does it require more medical time?
On the contrary, it's the giving intravenous that I think would require more cost. Because if a child would receive nebulized salbutamol and ipratropium anyways, so just adding, magnesium it's still the same cost. And if it is cheap to, and it's affordable, then I think we may have to think about adding it in the protocol, especially if the child has, severe acute asthma, acute attack, and a low oxygen saturation. So I think.
So I don't know, because if that is your scenario, you are going to be giving this isn't a trial of magnesium IV versus magnesium nebulized, because if you are given that setup as you say, you're going to go straight for the magnesium. Hasn't given us any evidence over that anyway.
Okay, but I don't think you were arguing not to give IV magnesium. And in practice, there's that small, my experience, there's that small proportion of children who come in where you they're getting IV magnesium and other things, and that cannula's going in right away. But there is also, and your experience may vary, that proportion of children where they come in and you think they're probably going to need IV treatment. The amitop is going on, if they're the right age, and you're giving them that sort of 30-45 minutes to observe their response, to wait for the amitop to cook, and then making that decision. That's often the way. That's often my experience. Right or wrong.
There are some children. You hope.
May I ask a question?
Yeah, of course.
Yeah. So I'm not sure whether the researcher choose the primary outcome as the score at 1 hour because it is more likely that this score is the result of the treatment, or just because it is the only one that is significant. Because for me, to choose or not to choose the magnesium nebulized at the treatment, I would look at the secondary outcomes instead of the primary outcome, because so no matter what the score at 1 hour be like, but I don't care about it as much as do you need a longer length of stay or not, or will you be intubated more or not, or so I would change all these secondary outcomes to primary outcomes.
I think that's a really, really good point. And actually, in a sense, how severe your symptoms are at 1 hour is not as important as whether you're needing intubation, ventilation, your admission, whether you get home or not, your length of stay, whether you got intravenous treatments. So put yourself in. So because this trial was pre-registered, you could actually go, it gives you a web address for the site, you could go and you could confirm that their protocol specified that this was the primary outcome. Yeah, because if that's not the case, what we're saying is that effectively there was research fraud. We're saying that the researchers set out to do one thing, but at the end of the day said, oh, all those outcomes are negative, so we're going to now say that the other things are primary outcomes. We could go and check. I'd be surprised if that was the case, but you never know. So put yourself in the researcher's shoes. Why do you think the asthma severity score at 60 minutes is their primary outcome?
So I would think that because they might not be sure that what will happen, what is going to happen after that, it may be like more dependent on other factors like the staff or the quality of care, things like that. But if it's for the first hour, it might be just because of the treatment.
So I think it's probably, this is pragmatism in action. Ideally, the researchers, I'm sure, would have loved to have set those things as primary outcomes. You've already seen that the confidence intervals around those estimates are very wide, where the confidence interval around the estimate of the effectiveness of magnesium is quite narrow. So with a smaller number of patients, they could power their study to demonstrate a difference at 60 minutes, which is still something, and which paves the way towards doing other studies. Whereas they would have had to have made a trial, who knows, maybe 10 times larger, to have any chance of showing effectiveness on those secondary outcomes. So there is a sense that actually this may be a logical stepping stone, that actually if they do this smaller but still large study, and we're able to say actually, you know, this treatment is not effective on your asthma severity score at 60 minutes, then you could probably discount it and say there's no point doing the larger study to look at the other outcomes that are more important to us. Whereas with this evidence that it is having a modest effect, actually maybe now they can start to say, do you know what, we should do a trial that focuses on those who we believe get the greatest effects and looks at the secondary outcomes and is suitably powered but would need to include a very large number of centres and becomes harder to do. So it's pragmatism sometimes. We can't do the perfect studies that we would like to do all the time. So we have to live in the real world with the evidence that we've got. So do we think that patients we look after in the UK are similar enough to the patients in this study for us to apply the evidence? Well, the study was conducted in the UK. What about those whose primary practice is elsewhere? How do you feel about the applicability of this evidence to patients that you would look after?
I actually think it's applicable because magnesium sulfate in Nigeria is not very expensive. And if I have to nebulize, just like I said, a child with salbutamol and ipratropium, then I can as well just add magnesium sulfate if it will, help me and make the child better.
So this is where we think about the application. There's often a Venn diagram we show. We think about the evidence, but it's not just about the evidence. It's about our clinical judgment and experience and the facilities in which we work. Is it practical? Is it costly? Can we actually do it safely? And the patient's values. Sometimes one may not count in so much. So patient values. What do you think patients would say if you asked them about, do you want me to add magnesium sulfate to your nebulizer? What do you think they would say if they come in very short of breath and you're prescribing your treatment and you say, hey guys, would you like some magnesium sulfate?
So whatever makes me better.
So I think this is an example. There are examples, of things where we would study this, where actually the patient values would be really, really critically important and central. We've got this great evidence, the evidence is knocked down, but actually the decision has to be really individualised to the patient in front of us, because their values may have a really important effect. I think it's fair to say in this case that probably the patient values are unlikely to be sort of vastly important. And if you say I've got a treatment which I think may be effective and shouldn't have any side effects, then many would be pretty keen for that. The evidence we've spent our time discussing, the clinical judgment and experience, well, we may bring to the table our personal views and experience of intravenous magnesium. Because if we've used magnesium and felt that it was a pile of rubbish, we might not actually feel that well disposed towards giving it nebulized. There are all these things that we may bring from our experience, and we may start trying it and make our own very biased assessments intrinsically of what it does. So I guess that brings us to the decision time. So we asked at the beginning if you had the scenario. So the scenario was a 5-year-old child coming in with a short history of wheeze, with SATs of 89%, a respiratory rate I think of 42 per minute, and with moderate respiratory distress. And you have this junior doctor who's questioned, would you like to add nebulized magnesium sulfate to the first nebulizer? What would your answer be now? So I'll just, for ease, we'll just say, put your hand up if you would say, yes, let's add the magnesium sulfate. Assuming you had no departmental policy that contravened that.
Yeah, there were no increased adverse effects in the magnesium sulfate group.
Yeah.
Why not?
Why not?
I think we should give it a
There was a chance
There's
of
a chance of sending one child
Yeah,
intubation and ICU and
Okay, anyone want to come back against that?
Yeah.
Okay. So he's saying more children get intubated.
Yeah.
Anyone coming back against that?
But none of those outcomes was significant statistically.
Okay, yeah.
Yeah.
The confidence intervals are so
We've got-
wide that it could
Yeah.
go either way. It's just not
Yeah.
really telling us any firm evidence
Yeah.
in either direction for that.
But it was just as wide for someone to be helped, just and same wide confidence interval for being harmed as well.
Yeah.
yeah.
But which do you think? Okay, but based on the effects on the asthma severity score at 60 minutes,
Yeah.
how likely do you think it is that this this would be increasing the risk of PICU admission? Do you think it's plausible?
Again, not that much.
Yeah, I mean, I guess you've got to bring in that degree
Yeah.
of judgment, and actually, given that it's shown on average an improvement in symptoms, I mean, by what mechanism could if magnesium sulfate is improving your asthma symptoms, what could it do that requires you to go to PICU? Anyone got any ideas from the possible side effects of magnesium?
Yeah, so cardiac, you always have to have a cardiac monitor, giving magnesium.
What does it do to your muscles?
bronchospasm. Is it broncho?
No, not really.
Bronchodilator.
Yeah, it is.
Oh, yeah.
Hypotonia.
Yeah.
So if you give loads of
Hypotonia.
intravenous magnesium, you can cause the reflexes to be absent, you can cause hypotonia. So you could theoretically cause respiratory failure, through lack of effort. And so has that been picked up through adverse effects? Have they picked up any cardiac adverse events? Have they picked up any patients who become weak and paralysed? I think they do give a sort of breakdown somewhere of the adverse events.
What's known as bronchospasm?
Okay, you just said adverse events. But
What's known of symptoms? Serious adverse. What's known of
The main side
exacerbation?
effects reported during the study were flushing, vomiting, headache, and asymptomatic self-routine, and transient hypertension. Didn't see anything.
There's nothing cardiac.
No cardiac. No unexpected adverse events.
And actually what's nice in a study like this is that so the clinicians who are doing the study, who are recruiting patients, they're obliged to report anything that could be an adverse event, any deterioration, any problem, even without knowing what treatment they received. So the beauty is then that when they get all those adverse events back, they can have a panel review them, even before they've unblinded, and they can look at them and say, do we think that this could have been caused by magnesium sulfate? So they classify it before even looking at who got which treatment. And then you can look at it when you unblind and say, okay, well, was there any association of the adverse events with magnesium? So I take your point. They haven't proven that this treatment reduces PICU admissions. They've just shown that it may have no effect.
Yeah.
The best we're left with is the null hypothesis, that there's no effect. That's where we have to start with until we've proven there's an effect. So let's do it. So that's a hands up. Based on the evidence you've seen today and the child you described, who would want to give nebulized magnesium
we need
sulfate?
to go over the child's
5 years old,
Yeah.
acute symptoms, SATs of 89%, moderate respiratory distress, respiratory rate of 42 minutes.
Just start with
Yeah, so who would want to throw in?
SATs of 89%. Yeah, why not? Yeah.
That's why I want to count hands. 1, 2, 3, 4.
here.
That's that's the point. The evidence is never going to push all of us towards. We're rarely going to push all of us towards the same decision. But that's still a change. Okay. Good. So on that basis, in our journal club, we like to think: is there any action that we should take on the basis of this? So if we're all in the same hospital, how would you like to take forward from this journal club? Should we take any steps, or should we just say we don't do anything?
In theory, I think, why not? It doesn't cause any harm, and it's greater if they're more hypoxic. But because of the, you know, the actual primary outcome of a reduction score of 1, and the bureaucracy involved of changing hospital guidelines, I don't think it's worth it for a...
Or is it worth your effort, I guess? Is that
Yeah,
what
no, not worth my effort. Thank you.
What about that motivated ST1 doctor who presented it to you?
Yeah, I say, yeah, no, good paper, good job. But, I would give it in an ideal world, but like bureaucracy will...
I mean, how much, other than changing the written guideline, which you could potentially give back to your very keen ST1 and say, off you go, here's the old guideline. So just saying, you could, like, I don't know, maybe something in there saying, like, it's not the standard, it's not the standard protocol, but you could consider adding magnesium sulfate in those children with low saturations. But it shouldn't prevent you doing your usual sort of escalation.
So look,
magnesium sulfate.
That's where it becomes really interesting. So I don't know if anyone has seen the BTS 2016 guidelines for acute severe asthma. Has anyone? So they took this evidence and they did incorporate it. And what they've done is they didn't follow the protocol of the trial exactly. So they didn't say, give them the first nebulizer, assess their response at 20 minutes, and then if they've not responded well, add the magnesium sulfate. Why do you think they didn't do that? I don't know, I wasn't there, but I'm guessing.
So they've said, give them the standard first, and if that...
No, they haven't said that. That's what the trial did. The trial said, you gave them the first neb, and then you assessed their response after 20 minutes, and you said if they didn't respond well, you added the magnesium. But what the BTS said was if you fell into one of those groups, if you were the really acute symptoms or the hypoxia, then you could consider was the word, adding magnesium sulfate to all of the nebulizers from the outset, which is different to what the trial did. Any ideas why they might have done that? And I think it ties into what you were already saying, actually.
Because I'm thinking because it's available in the hospital, and you know there are no documented added side effects.
Yeah.
And so why not start at the outset? Why do you have to wait?
Yeah, I think that's fair. I suspect also most of us working in a hospital in the UK will recognise that we're probably a bit slow to escalate our therapy, you know, and actually to take that decision to say, do you know what, this chap needs intravenous treatment. Sometimes we make those decisions a bit late, and I suspect that those who put the guidelines together would have been reluctant to do anything that introduces another step on the way to escalation, because what that could result in is that clinicians say, oh, they've come in, I've given them that salbutamol and ipratropium, they've not responded very well, so we'll try and nebulize magnesium sulfate, I'll disappear off to review some other patients, I'll get caught up, I'll have a cup of tea, and by the time you come back, you're very late to be escalating to intravenous treatment. That's my suspicion. I wasn't party to the discussion, so I don't know if the minutes are online. But it's it feels like they've taken the evidence, and they've taken a rather pragmatic application of it, which is quite nice to see from a sort of evidence-based medicine point of view. They haven't slavishly followed the protocol of the trial. They've said, we think we can use some clinical judgment and apply it differently. So that's the end of our journal club. As we wrap up, any sort of questions people want to throw in?
Yes. So in this case, I see they didn't really hold on to the fact that the changes were not clinically significant.
It depends. They were very clear about that. So even in the abstract, you would think as the authors they would want to say we found a statistically significant difference. They actually don't. They said the difference was clinically insignificant. So they laid their cards on the table about the clinical insignificance. However, what they ultimately do, if you do read their sort of interpretation and discussion, they sort of say, well, look, we've shown fairly convincing evidence that it has an effect, though small, but when we did our extra pre-specified tests, it looks like that effectiveness, rather than being a very small mean effect, it's probably a very minimal effect in a certain amount of the population, and quite a bigger effect in one group. So that's what they but I don't think they actually really sort of made a strong interpretation of that, and I think they've been clear that really we should get more evidence. But of course the British Thoracic Society, they review their guidelines every now and again, and like us, they just have to go off the evidence in front of them. And you can't always just sit there and say more evidence needed, more evidence needed, more evidence needed. And I suspect like what we've been hearing from the floor here, there's a sort of pragmatic take on it. where's the evidence of harm? Is it expensive? Is it burdensome? And actually, if we take the step and say you can consider introducing it from the beginning, they're leaving it open to clinician judgment, which is nice. You know, evidence-based medicine should always be open to our judgment, and they're not adding an extra step in their algorithm which can slow us down.
What does that mean for the dose of magnesium, 20 per kilo, I can't remember, that you would give if you would subsequently go on to give IV? Does there need to be some adjustment, or I don't know what the BTS says about
They
that, or they
mentioned,
just go ahead and give it?
they mentioned no change to the further protocol. Everyone was treated according to standard of care. I suspect if you compare the amount that was given via NEB to the amount that would be given intravenously, it's probably fairly trivial. It's 150 milligrams. And what's the dose of magnesium sulfate?
20 per kilo.
I would have to look it up because I spend too much time doing infectious diseases. But I have a feeling it's a thing to look at. And I sense then also it's going locally. It's not. I don't think it's all going to end up in your plasma. In a hurry.
So that would be the only concern if it was going to send some people in let's check with pharmacy. If it's going to slow you down from giving the actual magnesium.
But we know in this study that patients did escalate to IV therapy, and there's no mention of adverse events coming from that. So hopefully that's not been an issue. And I know we double dose quite a lot of people with magnesium sulfate, not at the time, but you know, after 8 hours, 4 hours. So.
Okay. Well, if it's in BTS sign, then you could be a bit more like, you'd just be like, it's in the guidelines, so why not? You know, what harm can it do?
And we've really thoroughly assessed the evidence.
And we have assessed the evidence.
So I was just thinking, in our setting back home, I think there's higher likelihood, I just think this is me, that the patient will come very late and in very severe case. So even though it didn't show very strong treatment effect, but they mentioned later on, like in the very severe groups, maybe in a setting back home, would I then be thinking I'd be more biased to giving it?
But they also said less effective with longer history of symptoms. So actually, if people are coming late after several days of symptoms, possibly less likely to be effective. And I mean, I can think of children I've looked after where nebulized salbutamol and ipratropium have been minimally effective until the IV therapy goes in. Probably just because they're so tight that it just doesn't get in. So I don't know. You know, so it could work either way. All right. Well, thank you so much for your participation, for all the discussion, and I guess it's back to work for all